Well, welcome everybody, and by everybody I mean all 4 people attending the session who are not otherwise involved in organising it. Welcome. This is our 12th question-based interactive journal club. It is also the final one for the moment because, well, you know, we're getting quite tired, although we love it and enjoy it. We have got Defna and myself, Serena and Aine today. Susie unfortunately pulled into clinical service. And let's get on with the show. Just to give you a quick review of what we've done over 12 weeks, because you may extraordinarily not have attended every session that we've run. We've looked into such interesting questions as should we consider giving ondansetron to children attending A&E with paediatric head injury and vomiting? How long should we give penicillin for in throat infections where indicated? How strong is the evidence behind ibuprofen as a risk factor for empyema? Are probiotics of benefit in acute gastroenteritis? Evidence for superiority of high flow oxygen, humidified oxygen over CPAP for preterm neonates, lumbar puncture utility in young infants with UTI, crew resource management training for resus quality, conservative versus operative management for appendicitis, whether characteristics of the transition process in adolescents with chronic illness is associated with improved outcomes, drug holidays in ADHD, and last week the quality of paediatric epilepsy care and its effect upon unplanned admissions and adolescent mortality. So we've had quite a diverse set of questions. Outline of what we usually do: we usually have a very brief chat about EBM principles and process, just aware that not everyone who comes will have been to sessions before. I was going to do a tiny bit on searching, just as a little bit of extra education, and then we'll have Serena presenting a clinical scenario leading to a focused question, a search, and a selection of a piece of evidence. We'll then have 20 minutes to look at that evidence on our own effectively, but asking questions if we want. And then we'll run through that together and see what we think of that evidence, whether it would change our practice. And then we'll wrap up. So evidence-based medicine, I think one of the most common misconceptions is the idea that it's just about the evidence, that it's basically, well, you know, you throw out everything else you know and you just rely upon the latest randomized control trial or meta-analysis or whatever. It's never really as simple as that, because the evidence requires interpretation. The evidence is almost never perfect. There's often multiple pieces of evidence, and that has to be used in context with the expertise of the clinician, who may have good experience and reasons for you know, using that evidence or for not using it in a particular circumstance. The patient's own values and what they want, what matters to them. And then the specifics of where we're working. You know, it's something, there might be good evidence for something, but it might simply not be possible and practical in our environment. So actually the integration of these things requires a lot of judgment, and it's about a lot more than just a bunch of numbers. You'll have seen that a lot during the endless debates about masks and all sorts of things during the coronavirus epidemic. The process we tend to follow is the sort of canonical one that's thought of in evidence-based medicine, the idea that first of all this starts in our clinical practice, and that we actually have to recognize uncertainty. So we're not really going to go on a journey of looking for evidence and answers if we don't have any uncertainty. So in practice, a clinical scenario should lead us to a question, some sort of uncertainty. We need to focus that down into a scientific question that's answerable by distilling the most important factors. And then we need to be able to search for the evidence that's going to help us answer that question, appraise that evidence to see if it has any chance of being valid internally, so valid for the population on who it was studied, see what the results show, and then think about whether we can take that evidence and apply it to our population. That will lead us to make a decision, and depending on the strength of the evidence, that might be a very easy decision, or that might be something that requires some discussion and consensus, particularly when thinking about guidelines. And ideally, we want to have some idea of the impact of that decision, whether it's for a single patient or for a guideline and impacting lots of patients. In our journal clubs, we have a nominated team or individual usually who has done the scenario setting, the focused question, the search, and then as a group we appraise, and maybe that leads us to change our decisions together. Although the sort of caveat that I always give is, of course, we're not here to give clinical advice, and we're not here to override local guidelines. So if you do come across evidence through what we're doing here that you think mandates a review of local guidelines, of course, do take that on. So yeah, so hopefully we learn by example and learn by doing. Focus questions, just to idea that one of the commonest ways we frame a focus question is to think of what patient group or population we're talking about, what intervention we're interested in, if it's a treatment, or exposure if we're talking about risk factors, what we're wanting to compare it to see if it's better or worse, what outcomes we care about, and ideally over what sort of time scale. You know, are we talking about short-term outcomes or long-term outcomes? You can use this PICO framework for questions about treatments and tests, prognosis and risk factors. Sometimes people feel it's a bit of a straitjacket, but at the end of the day, it's just a tool to help us make clear what question we're asking, and so we can think critically about evidence and whether it really speaks to the questions we're interested in. We also talk a lot, you often find people referring to hierarchies of evidence. There isn't just one hierarchy of evidence. It does depend on the type of question you're asking, because depending on the type of question, different types of studies will be most suitable. The canonical one that's often presented is the hierarchy for interventional questions, where you've got sort of sitting at the top of a tree, systematic reviews and meta-analyses of randomized controlled trials, and then below that randomized controlled trials. But even that is not set in stone, because the quality of the individual study matters. So actually, if you've got a question about an intervention, it may well be that a really well executed observational study might be better evidence than a really small and potentially biased randomized controlled trial. So it's not, none of this is sort of set in stone. I wanted to just briefly, because I'm aware we never have much time to do specific formal teaching in this, but I thought we may as well just make sure that people are aware of two different ways to search for evidence when you have questions and you want to. The first one I want to introduce is perhaps the simplest and quickest, and it's one that I often use if I'm at work and I only have a short amount of time to see what I can find. It's called Trip Database. Tripdatabase.com, turning research into practice. It's pretty much run by a single person in Wales, as far as I can tell, and it's been a labour of love for a number of decades. And what this site does is it pulls guidelines and published articles from a lot of different sources, but it focuses specifically on those that tend to be at the top of the evidence tree. So it's really focused on not laboratory research and things like that. It's really focused on pulling clinical guidelines, systematic reviews and meta-analyses, randomized controlled trials and things like that, cohort studies all together. And it's got a very simple searching interface. You can search with a PICO tool just to help you frame what you're doing, but so I've used it before, so I think I may have even used it for ondansetron in head injury. So you can just throw in a few tools. Oops, I missed an N out. What it tends to do is it promotes what it thinks is the highest level of evidence. So if there are systematic reviews or guidelines coming up, they will float to the top of the search, and you can filter on the right as well. So actually you can see one of the first articles that comes out here. I think this is actually the article we selected to look at. Use of ondansetron for vomiting after head trauma, does it mask clinically significant traumatic brain injury? So it's not perfect, but it's often a really good way of getting you quickly to a single piece of evidence that may help you with your question. If you're wanting to look a bit more systematically, you might want to go somewhere like PubMed, www.pubmed.gov, and that searches a large Medline database and some others. The search interface looks deceptively simple, and you can just throw words in, but it's worth being aware that it's much more nuanced than something like Google. There are lots of things you could learn about using PubMed, but one of the main things I think is useful to know is about using binary terms or Boolean terms. And that's the idea that you may want to specify a list of things of which at least one must occur in what you're searching for. So for example, if you've got synonyms for something, if you want to find articles that are about antiemetics, you may want to search for things that are about antiemetics. You may want to also search for antiemetics as two words. That will also cover it with a hyphen. You may also want to search for specific antiemetics. So I can put all those together. That will search for any articles which contain either of those three phrases. And then if I want to say I also want to limit it only to articles that contain the word head injury, what I can do is put brackets around that and say that's one thing, but then I also want the article to contain the phrase head injury. I can put that at the end. You actually don't need to put quotes around phrases, but I always like it. And you can see we go from 160,000 results down to 142 results very, very quickly. Oh, what do we see? Actually, interestingly, it's the same article that comes to the top here. And you can ask it to sort things by date or by how well they match the thing you're searching for. There's a whole load of other things that you could be shown or learn about using PubMed. One other thing that I'll just point out is there is a thing called clinical queries linked to from the main page. That allows you to do a search in just the same way, but it also then filters it by the type of question. So you can say, this is an interventional question, and I want you to restrict it to studies that are likely to be answering an interventional question. So it reduces the number of results you get, which means you've got less to wade through and hopefully still keeps the things that are relevant to you. So yeah, that is what I wanted to show you. Let's get back to the slides. What happened to my slides? Where are the slides? There they are. All right. So over to Serena.
Thank you, Andrew. My name is Serena. I'm a general pediatric trainee with an interest in pediatric allergy, and I'm currently working as a pediatric allergy registrar at St. Mary's. The clinical scenario that I chose for today is something that is a real-life clinical scenario and a situation that many of us may find themselves at some point while in clinic. So in my case, I was in a general pediatric clinic, and I was reviewing a 3-year-old child with moderate eczema and multiple food sensitizations. There was a strong family history of HOP. Mother has asthma, father has a hay fever and nut allergy, and mother has just had another baby who is now 2 weeks old. And she's quite worried because allergies run in family, and she asked me whether there is anything she could do to stop her newborn baby from developing eczema. I know that emollients are used to reinforce the skin barrier, and they are used to prevent flares in eczema. So I'm wondering whether using emollients may help with preserving the skin barrier, the skin integrity, and so preventing these, the development of the eczema in this newborn. Next slide. Yes. So my clinical question, I structured it as with a PICO structure. So I want to know whether in healthy infants at risk of developing eczema, whether the use of emollients versus no emollients prevent the development of eczema. So my population is healthy infants at risk of developing eczema. My eye intervention is the use of emollients versus comparison, which is no use of emollients, and my outcome would be the prevention of eczema. So yeah, just a background, as I mentioned before, we know that atopic dermatitis or eczema is due to a skin barrier dysfunction, which may precede, maybe there before actually the clinical development of eczema, and that the use of daily moisturizers reduces the risk of flares in patients with eczema. So my search, I did it on Ovid, which is another search engine for publications, and is based for medical publication, is based on Medline and Embase. So I did this search. So I search infants and neonates, emollient or moisturizer, eczema or atopic dermatitis, and prevent as could be preventing, prevent, prevention, and then I put all together with and at the end, after deduplicating my results, I had only five results. I was very pleased with that, so I didn't have to go through many of them. So the first result is daily emollient during infancy for prevention of eczema, the BIP randomized control trial. So this is a quite large study published in 2020, so very recent. It's about the population, I think, is about 1.4 thousand infants, and is based in UK. I had a look at the abstract for the second study as well, which is a Swedish study, where population actually is much bigger, is about more than 2,000 infants. And they are randomized in 4 groups, a control groups where no intervention is used, a group where only emollients, daily emollients are used, a group where emollients and early introduction of food are used, and a 4th group where only early introduction of food are used. So this is quite interesting as well as a study. Then I didn't put on my slides the study number 3, because for some reasons, even if I did applicate my search, I still have a duplicate. Was again the Swedish study. So study number 4 is a US study. I had a look at the abstract. I was quite interested in this study because the senior author, Dr. Simpson, is a quite renowned allergy specialist, pediatric allergy specialist, and is present on all the international conference in pediatric allergies that you can go to. So I was quite interested in this study, and I was hoping to have some answers from that, but unfortunately the authors themselves in the abstract, they comment on the fact that their population was very small. They were aiming to have a population of at least 200 infants, but actually they didn't reach 100. So their results were not clinically statistically significant. So I excluded this study from my search. And the 5th study is a conference abstract, so I didn't have a full paper to analyze. So between the first 2 studies, the BEEP study and the Swedish study, I prefer to go for the English one, for the British one, because I thought this is my population, so it's more likely that the results of the study are going to be more they're going to be more reliable for my child.
Some of the authors.
Ah, yes. So yeah, so I decided to go for the BEEP randomized control trial study.
Great, thank you, Serena. That's wonderful. So, if you've been here before, this will be no surprise to you. What I'm going to do is share a link that you can follow here. It will give you a number that's either 1 or 2. And if you get a 1, we'll give you a task of looking at the validity of the paper. If you get a 2, we'll ask you to look at the results of the paper. This is a Dropbox folder, which should allow you to download both a CASP assessment appraisal pro forma and the paper itself. If you have any difficulty with those, these are the links to the files directly. And if those don't work, I can probably email them to you. So if you get a number 1 on that link, then, oh, ignore my NB there, that's irrelevant, that's from last week. Then you'll look at the validity, and that means you're going to read the methods and a demographic table, which is usually table 1. And also the abstract is a great way to get an overview of the trial. Forget about the introduction, forget about the discussion. And you're going to then use the first set of questions within the appraisal pro forma. If you got a number 2 and you're asked to look at the results, then read the abstract as well, but then dive into the results and look at the questions in the appraisal pro forma, which are about results. There's a final section of the appraisal pro forma, which is about applicability, and that's what we then start to talk about when we come back together. But if you finish what you're supposed to do, by all means, look at the other. So if you finish looking at the results, look at the validity, and vice versa. And if you hit any snags, there's things that don't make sense, that are causing confusion, we are here through the chat, so you can type a question, we can answer it as best we can before we all come back together to discuss things. We'll give you about 20 minutes for this. It's quite a big ask, but don't worry, we do it together, and there's no prizes for finishing or otherwise. And just to remember, when we talk about assessing the validity of the study, what we're thinking is, are there factors in the study design or the execution that might mean that the estimates of the effectiveness of the treatment are biased? pushed in favour or against the treatment. And if you're asked to look at the results, then you're looking at what are the estimates of the effect of this treatment from the study, and how precise are they? So that's about their confidence intervals. And do those confidence intervals exclude the number that corresponds to no effect? So if it's a relative risk, no effect is 1. If it's a risk difference, then no effect is 0. So there you go. It says up to 30 minutes. It's actually 20. So we will start now. So it's 1:25. So we'll come back together by 1:45 at the latest. Let us know if you're struggling to download anything. Yeah, off you go. Have I missed anything, Defna?
I was just going to say we didn't ask what we think
yes.
we would do.
Go on, you ask, Defna.
All right. To everybody, before you read the paper, what is your original thought about this? Do you think emollients will prevent eczema? You can type or chat. Okay. Serena says yes. Satish says yes. Andrew says yes. I was indifferent. I didn't know, so I was abstaining. Anyone else? Okay, so overall we have an opinion that this is going to be useful. All right, let's go ahead with the paper then.
Great. So we're all here. Send us messages if you want any support or suggestions.
Just a couple more minutes left, and then we'll come back together in 2 minutes. Okay, let's get back together and see what we think about the paper itself. I think we've lost Andrew, but he will come back, I'm sure, at some point. So let me share my screen so that we can get onto the CASP tool. Just bear with me for a second.
Sorry, bad internet.
That's all right. Do you want me to share the screen, Andrew? I'll just share it for now.
It's hopefully all right. I'll bring it up. Oh. Okay, fine, because you're going to be doing the typing anyway. That's right.
Yeah.
Is that what you're missing? Okay, fine. Great.
So
well, it's 1:44, so probably a good time to pull back together anyway.
Yeah.
All righty.
Perfect. Right.
I'm just bringing the chat box up. So we're going to start by feeding back about validity, hopefully over just a few minutes. So can we get people's views on whether the trial addressed a clearly focused issue? Can you tell what their PICO is? Got a yes? Yeah. I'm wondering if I'm looking for responses from anyone who's not involved in organising the session as well.
Satish said yes.
Oh, good. Oh, sorry, I missed that. Yes, great. All right, super. Okay.
Satish, can you tell us what the PICO was? While he's typing.
Satish, if easier, you can also switch on your microphone.
Oh. Yeah, we're getting healthy term babies, greater than 37 weeks gestation.
And I think they had to be 28 days or younger, so neonates when they were recruited.
Recruitment.
Their intervention was emollient.
Hi,
hello.
Hiya. Sorry, if I had known that you would ask me questions, maybe I would have just muted myself. Okay.
Oh, did you? Oh, yeah. No problem.
Because not
Sorry, I
many
was just
people
asking
saw-
about
yeah.
the peak.
So you singled out to me, so I had to come out. So anyway.
I've just got to the outcome bit.
So
Did you
I
want
think
to
the
say?
outcome, well, yeah, so they did not find any evidence, so it did answer their primary question.
Okay. Did you see what outcomes did they look at? Can you remember some of them? The main outcome, and I think they had some secondary ones as well.
The primary outcome was whether there would be any benefits of emollients in terms of developing eczema or not. So this did not.
Yes.
And that was
We'll get to that in a second.
Yeah.
So they looked at whether they developed eczema at 2 years, 100%. So that was their sort of main outcome. Did you come across any other things that they looked at as well? Any other outcomes that they measured about these children?
Regarding egg allergy, something.
Yeah, I think there was it's quite complicated when you read it, because they looked like they considered quite a lot of things, but they were also looking at whether they developed allergies as well. And they also looked at complications like skin infections. Great, thank you very much.
Thank you. Sorry to single you out.
I'll go back into hiding.
Okay. So next question, was the assignment of patients to treatments randomized? And were you happy with how they were randomized? You can type or talk. We got a oui. Got a yes. So Aim, can I prevail upon you to tell us whether you were pleased with how they randomized, or whether it leaves you with any questions?
I think they tried as best as they could, so it's computer-generated randomization program.
Pleased, good. Yeah. And they went on at length about stratification and blocks. It's not something we tend to dwell on, but does that sort of mean anything when you read that? All right, so we may as well just, so briefly, the stratification is designed to ensure that you get similar numbers from each of the strata in each arm. So their stratification was by how many family members had an atopic history, and what was the other one? There was a second thing. A hospital site. So I think there were 4 different hospital sites or something. So they wanted to ensure that you didn't by chance get a sort of, an over-representation of a particular hospital. So what you do is you make your randomizations distinct. So you have a different sequence of random numbers for each of those potential strata. And you use this block randomizations within that, which means that you can never, if I toss a coin, I might toss a coin 10 times and I might get 7 heads. And 3 tails, so I can get an imbalance. But the block randomization ensures that you can never get that far out. You'll always have roughly 50-50 in either side. So useful to be aware of. It's just a way of ensuring balance. All right, number 3. Were all of the patients who entered the trial properly accounted for at its conclusion? So it doesn't mean did everyone who started the trial finish the trial, but it means can they account for what happened?
I think
I'm
so.
not sure if I missed this entirely. Sorry, Serena.
Question, Andrew.
Yes.
Sorry, could you repeat the question? Sorry, I missed it.
The question, did they account for all of the patients who entered the trial at its conclusion?
Okay. I think they've given a broad, though I did not have time to work it out with all the calculation, they have mentioned in their flowchart how many were excluded and what were the dropouts and other things. So
yeah,
yeah,
great. And that like the flow chart is the key, because it sort of gives you that idea of how many go through. Yeah, what do you think of the fact, so they had 5,000 families who were potentially eligible, but ultimately ended up with 1,400 babies who were randomly assigned. So lots of people who were potentially eligible didn't take part. Does that give you any pause for concern?
Yes, it does. I think it's mainly due to the duration of the research. Could that be it?
Mm-hmm. Yeah, I mean, it's 2,000 of them just declined to participate. So they were approached, but didn't want to participate. And I guess the thing to be aware of is it means that you're not necessarily looking at the general population. You're looking at a sort of a bit of a subpopulation who were willing to take part in this study. Doesn't mean that the answer's wrong. It just means you've got to be aware that, you know, this is not necessarily totally applicable to the general population. Great. All right, but yes, so they can account for people. And of the 1,394 babies who were randomly assigned, if I add it up, it looks like they managed to get outcomes on about 1,200 of them, 1,210. So they lost 184 out of 1,394. So roughly 85% that were randomized, they could analyze at the end. So, you know, for a study that was analysing outcomes at 2 years, I would say that's pretty good. All right.
The only thing that I don't know if I missed this, but did they statistically tell us how they were going to account for the loss of follow-up?
Well, the methods are quite meaty. I think they use quite a few different approaches, but I think in the crude one, they just analysed. So the people with the primary and the people for the primary analysis were there because they have the primary outcome. So they know which group they were in and they know whether they had eczema at 2 years or not. So they have that data for everyone. That's the key
bit, that whoever stayed in that group remained in that group in the analysis as well.
Yes, so that's that hint. It says, were patients analysed in the groups to which they were randomised, and the answer is yes. So even though some of the children in the control group were given daily emollients, they were still analysed as if they were in the control group and vice versa. All right, number 4. Was it blinded? So patients, parents, study personnel, who was blinded in this study?
So it was quite difficult, I think, to blind the parents because they were the ones to apply, they had to apply the cream. So the parents were not blinded, but it says that the research nurses who were then assessing the presence of eczema at different stages, they were blinded.
Yeah. Okay. And Serena, are you worried that the lack of blinding of the parents will influence the outcome? Do you think that will cause some bias in this study?
I'm not sure.
I totally agree.
Yeah.
There's definitely a placebo effect because some parents think that there'll be. Sorry, Serena. Maybe I should have let you answer that first.
No, it's good to hear.
Because many of the parents, if they're told that this is the emollient that you're applying, some will say, okay, yes, because of this, the skin health is better. So again, depending on how they receive it, there would definitely be a placebo effect on the parents.
Yeah. And the devil might be in the detail of exactly, they said they used this standardized assessment at 2 years to identify if there'd been eczema in the previous year. So that obviously not just involves looking at the child in front of you, but asking the parent some questions. So I guess you'd be thinking, is the knowledge that they use these emollients affecting how the parents respond to these questions? Yeah, good. So there is a potential source of bias there. Okay, number 5.
Sorry, just one. And also, I'm not 100% sure how good the nurses were blinded, because when you speak to the parents, I'm sure, even if I want to hide that, while speaking to them on the phone during follow-ups, I'm sure at least a few of them would have automatically come out saying, we applied this.
Yeah. It's a very good thing to point out. They did actually mention, I think they said about 3% of cases there was accidental unblinding at the 2-year visit. 41 out of 1,190.
Oh, right. Okay, I missed it. Yeah.
Yeah. So a small problem.
That's declared, isn't it? You don't know. I mean, you'd assume that everyone declared, but
yeah. So number 5. Sorry, go on. I'm hearing a voice.
I was just going to say, Serena first said that you couldn't blind the parents. But I wonder whether or not if you just had a tube of something placebo versus the emollient that you're using. You could, I mean, it's an expensive way of doing it.
But that's really hard, because how do you know that your placebo is not going to have an effect?
That's true. I mean, unless it's like water.
Yeah, and I think people will know they're rubbing water on their baby.
Yeah.
You won't know.
Okay, so were the groups similar at the start of the trial? That's table 1.
How do people feel about the comparisons in table 1 in the control group versus the treatment group?
So I've got yes from Serena. Yeah, yes from HFJ, and you can see actually the stratification has done its job as well, because the numbers, the absolute numbers of first degree relatives and things is very similar. So let's not labour that point, that's a yes. And in fact, in the interest of time, I'm gonna say, aside from the experimental treatment, were the groups treated equally? That's pretty much yes. The only thing the experimental group got was the emollients and the instructions on how to use them. So treatment effect, how large was the treatment effect? What's your sort of key results from this study? I know there's loads of results here. Okay, you've got some very suggestive behaviour there going on from Defna.
I'm just aware of the time.
And time is limited, yeah. So the key thing here is whether you look at it on the relative scale, relative risk, or the absolute scale, the absolute risk difference adjusted, and that's controlling for some other factors, then you get very small effects, and also with confidence intervals that clearly cross the number of no difference. So the relative risk confidence interval crosses 1, the adjusted difference interval crosses 0. So that's telling you not only is the estimate of the difference small, it's also not significant. So we can't even say that there's a real difference in the population. So yeah, a small or effectively null effect, we can't show that there's an effect, even though they recruited enough infants according to their power calculation. All right, great. So that makes our life easy. Did they find any other significant outcomes, anyone, when they looked at, I don't know, the food allergy stuff and other stuff? Did they report those? So that's other definitions of eczema there. And then I think there's a food allergy table, table 3. And a quick glance down there, I see lots of confidence intervals that are wide and cross 1. So it doesn't really look, and that was not what the study was primarily designed to assess. It looks like that was something that was added partway through the study. Okay. And the other thing is, if we look at the confidence interval, which I'm just writing into the chat, do you think have they sort of ruled out an effect that they said that they wanted at least a 30% reduction in eczema? That was what they considered to be clinically significant. Have they kind of ruled out a 30% reduction in the risk of eczema? And how would we answer that?
I had made a table.
Oh, nice. But just to say, if you look at the confidence interval, the relative risk confidence interval goes from 0.78, which is a 22% reduction in risk, up to 1.16, which is a 16% increase in risk. But actually that confidence interval is precise enough that it actually it doesn't include the possibility of a 30% reduction in the risk of eczema. So you would say actually, really, not only have they not shown a significant difference, they also make it look very unlikely that there could be a reduction of 30% or more, even if we did more studies. So it's suggesting that even if there's a small effect that we've missed, it's likely to be, a much less clinically significant effect. So this is what I would say a useful negative. A useless negative would be one where the confidence interval goes from a 60% reduction to a 500% increase. And you say, well, that's meaningless. It doesn't help us at all. This is actually giving us some sort of window within the true effect might lie. It might be no effect, but it might also be a relatively small effect that might not be worth slapping emollients on your baby every day for 365 days. All right. So applicability. Do you think there's any reason we can't apply these results to a pregnant woman in clinic or a friend of ours who's giving birth where there's a high risk of eczema? I'm seeing a shake of the head.
As Satish said at the beginning, this is very similar to our population, but there is a kind of selection bias there, because people who actually, because we had quite a big number of people who didn't take part despite they were possibly eligible. So there is a bit of a self-selection there of the population who actually take part in the trial.
Yeah. Yeah, so we may be sort of thinking, well, actually, well, the person we're talking to is definitely someone who would jump into that sort of trial. So we think it really applies to them. Okay, and this is always the quite creative bit. Do you think they looked at the important outcomes? Do you think that there are actually other outcomes they should have considered in this study that they haven't looked at? Could they have missed some other beneficial effect? Facetiously, I would say they could have looked at maternal infant or paternal infant bonding, because maybe the shared experience of slapping emollients on every day for 365 days is like a sort of intensive baby massage course.
Yeah, that's a really good one.
Thanks. Any other ideas?
Well, I'm not sure from I don't know, no psychological effect, but it's kind of a big task to ask parents to apply emollients every day.
Yeah.
So they could have seen also, like, waste of time and remembering to apply the emollients might have an effect on parental mental health.
Yeah.
Which might be quite labile in the beginning.
I think HFJ does have a point, though. I know, Andrew, that they do present some data talk. So
yeah, I mean, it's basically the first bit of the results. I mean, it's based on calling them and asking them.
Yeah, but they fundamentally.
Worst case scenario, it was 50% compliance.
Yeah, exactly. So that might.
And then you also had quite a number of the control group. I think it was about 10% who still applied these things anyway.
Yes.
Yeah.
And there'll be an element of not remembering.
Yeah, well, or just deciding I should do it anyway. I mean, I'm sure some parents do apply quite a lot of emollients anyway. So question 11 is moot. Are the benefits worth the harms? Well, we haven't seen any benefits, so we don't really need to dwell on that. So has this evidence changed our opinion? Maybe just pop that in the message box. Has this changed your view on whether emollients are useful for preventing eczema in high-risk infants? So what do you now believe?
I think there was a one abstain and many yeses.
Yeah, I was a yes.
What do you think now, Andrew?
I think it's likely ineffective, sadly.
Yeah. It would have been a really easy, like a really good way of doing it, to be honest.
Yeah, I bet the study team were very disappointed because, of course, you want the positive result, but it's a useful negative. It means you don't have to bully people into doing this quite cumbersome thing.
Sorry, Andrew, I missed it again. So what was
the question? I was just asking whether it had changed your opinion. So we asked for people's opinions on emollients as preventatives for eczema in the beginning, and whether this has changed your views.
Okay. For me, no. I mean, I don't want to ask parents to continue applying it, but it's a big. I don't know. I need to look at more evidences or look at more research.
the beautiful things, there are
say
some of the
no,
studies you can look at.
because we are kind of taught or imbibed saying that these are all good things that might prevent.
Yeah.
But coming to the practicality, I don't know if
Yeah.
I change my practice, I would still continue to say or ask parents to apply.
Yeah. Yeah.
I
think it would certainly make me unenthusiastic. Yes. Jane.
I just to point out that obviously this is double base gel and double base cream. So, I mean, we could argue that you don't know what other emollients do.
It's always the problem. It's the same arguments with probiotics, isn't it? In preventing neck, you know, did you use the right probiotic? Those ones didn't work, but the other one will. Yeah.
Yeah, I mean, I think what's really interesting is that it may cause harm from sort of increased infection.
Yes, actually, we did forget to mention that there was the signal of potentially increased evidence of skin infections in those who use the emollients. I don't know if that's from one of the tables or not, but it's in the text.
Okay.
And I think really important to also remember that obviously we're talking about the prevention of eczema in high-risk infant, not
not the treatment of eczema. Yes, 100%. All right, should we go back to the slides, Stephanie? So yeah, no apparent harm, but actually possible harm through some increased skin infections.
Andrew, do you mind? I didn't download the.
Yeah, fine. Yeah, there's a share
Let's do a
screen.
swap.
Just to wrap up. So yeah, there isn't really a lot to say. We've had a lovely time. We hope that you've had a good time attending. This is our last one. If you've not been before and you've not given us feedback on these sessions, we'd love you to have it, because we are in discussion about what the London School might do to promote evidence-based medicine learning locally and across London in the future. But this is the end of our series for now. But so feedback's still valuable. We do have some useful resources if this highlights to you things that you want to learn. So here are some links. They're on the screen as well. There are some e-learning courses that I believe are free. And then there's the two sources of information in the Oxford Centre for Evidence-Based Medicine, the Critical Appraisal Skills Project, whose pro forma we used. And then if you want to see it in practice, I would highly recommend you always flick to the Archimedes section of the Archives of Disease in Childhood, which has, again, quite small, simple questions, reviewing a few studies to see how they answer those questions. It's always informative. And don't forget the Bubbles, the online educational resource, has a evidence review called Bubble Wrap. Yeah, so thank you very much for your participation. We've enjoyed this, hope you have too, and maybe we'll see you again in a similar venue another time. Bye-bye.
Thank you.
Wonderful. Thank you so much.
Thanks.
Just
Bye-bye.
one quick word.
Oh, yes, question.
Was involved in this, so it was really a wonderful week. So I really wanted to thank everyone who has organized this allergy week. I mean, yeah, I should say, because I'm into allergies just now, I'm more focusing on allergy, but the whole LSB has been fantastic. And more importantly, the recording of the sessions is such a boon for us. So we can come and have a look at it at our free time as well, or go back and revise as well. But to the allergy team, thank you so much. And also especially the one who was DS, sorry, I don't know her name, to bring me up and stimulate with more. This
is the most interaction we've ever had.
Yeah, I mean, really, I think this, especially all this statistics and the research part of it, it's way beyond some people's. I mean, for me, it was way beyond my reach as well. So yeah, I need to develop more skills regarding these things, and I think you all done a really good job. So I'm really keen to improve my skills on this. Thank you.
Great. Well, and we think that we learn much more by doing it together. And I think the traditional journal club, where one person has to present the paper, you don't get the same opportunity to learn together. So we hope that this is effective in some part.
It was.
And I hope that some of the resources might be useful to you as well.
Thank you.
All right.
Bye bye.
Thanks all. Bye bye. Bye bye.
Thanks everyone.